Hi guys, this is Caitlin McDowell. I am one of the interns this year, and this is my virtual journal club. First, I just wanted to say thanks for taking the time out of your day to watch this. I know these are unusual circumstances, but I'm still happy that I have the opportunity to present at Journal Club this year. Um, so thanks for taking the time to watch it. The Journal Club article I chose was published earlier this year. It's from the Journal of Alternative and Complementary Medicine, and the title of it is Thalamic Gamma Aminobutyric Acid Level Changes in Major Depressive Disorder After a 12-Week Iyengar Yoga and Coherent Breathing Intervention. And so, just briefly, I kind of wanted to go over my interest and kind of like background in this topic. And so, prior to medical school, I started practicing yoga for like physical benefits back in college, and I did it with other exercises. And then during my third year of medical school, when I was on rotations, I started kind of craving something more for my mental health. I was just kind of feeling a little bit more anxious and unsure just with that transition. And so I started going to yoga a lot more. And through yoga, I was able to kind of utilize my own mind body connection, and it helped me with that. And that's where my interest started. So I started doing more yoga during my third year, and then I had my third year rotation at Twin Valley, and that kind of solidified my own interest in psychiatry and mental health. Um, and then this led me to conduct research during my fourth year of medical school, and we had more elective rotations. So during my fourth year of medical school, I did a literature review of complementary and alternative treatments for anxiety and depression. And so I found that there have been many studies done on yoga for depression indicating positive results for using yoga like as an adjunctive therapy, but most of the studies had small sample sizes, and also at the end would just say there would be more research needed. And a lot of these studies used subjective scales to measure anxiety and depression, and didn't have as much objective data as far as like using an MRI scan or researching different neurotransmitter levels and stuff like that. And so when I came across this article that was recently published, I thought, it was a change in what I had seen a few years ago when I did do that literature review, because it is showing objective data as far as GABA levels relating to a yoga intervention. So that's kind of why I chose this article, and why I wanted to present on it. And then also during my fourth year of medical school, I studied to become a yoga teacher. And so during this presentation, I figured it would be a good opportunity. Well, I had like a vision when if I gave this in person, we could do like a little bit of yoga in person, but that's clearly not going to happen. But I thought during this presentation, it would be a good opportunity to maybe do some breathing exercises. And the good thing is it's being recorded, so if you're not into it, you can just skip forward. But yeah, so that's also where my interest lies, and I do hope to one day integrate yoga with psychiatry into my practice. Okay, so just a little bit of background on this. The World Health Organization ranked depression as the single largest contributor to global disability in 2015. So it just kind of highlights this is a problem. It's estimated that 40 to 50% of individuals with MDD do not achieve remission with medication alone. So medication can help, but other adjunctive therapy can also help with remission as well. Individuals with complete remission from an MDD episode have a 61% lower risk of recurrence and remain free of relapse or recurrence 4.2 times longer than those who continue to exhibit subsyndromal depressive symptoms. So achieving, that complete remission just has a better outcome for people. Currently, we all know this, but the first line treatment of MDD is SSRIs based on the monoamine deficit hypothesis. And then in people who are severely depressed, over 50% reported seeking complementary and alternative medicine treatment instead of psychiatric treatment. So it's interesting because from our perspective, we see a lot of people coming in that want psychiatric treatment, but it's also important to remember that out in the community, a lot of people don't come to us first. They're going to go to other places first, and they're going to try other things first. And then approximately 14.9 million Americans incorporate some form of yoga practice into their daily lives. And so people are beginning to do yoga more and more, and it's something that, can easily be brought into somebody's daily life. And it's something that can ultimately help people with their mental health along with medication and stuff at home. So, some more background about the monoamine deficit hypothesis. So, just basically, it hypothesizes that the underlying pathophysiologic basis of depression is the depletion of levels of serotonin, norepinephrine, and/or dopamine in the CNS. And we know this just from the different medications we use to treat anxiety and depression. It's supported by the fact that antidepressants have helped with those symptoms and kind of the underlying mechanism of action behind antidepressants. But, as we know, there are kind of some inconsistencies with the theory, just looking at even other classes of medication. So, lithium can be used to treat depression, but does not, chronically increase synaptic concentrations of monoamines. Cocaine, which is a potent inhibitor of monoamine reuptake, has no antidepressant activity, like long term, and antipsychotics that block the dopamine receptor are not generally associated with the induction of depression. So, just some food for thought regarding that hypothesis. So, this article utilized the GABA deficit hypothesis, and it was really interesting to me because I had actually hadn't learned about this hypothesis yet. I know GABA is an inhibitory neurotransmitter, and it, has to do with more anxiety, but I didn't think about it as much for depression and wasn't familiar with this hypothesis. So basically, this hypothesis hypothesizes that the underlying pathophysiologic basis of depression is related to deficits in the GABA system, specifically the GABA A receptor. And it's supported by studies that have used MRS to show GABA levels are low in MDD subjects. And then it's also based on the connection between the GABA system with progesterone levels, specifically that decreasing progesterone levels increases depressive symptoms. And so this was really interesting for me to learn. So basically, progesterone is metabolized to allopregnanolone, and that is a positive allosteric modulator of GABA A receptors, and it has anxiolytic and antidepressant effects. And so basically, progesterone, you can think back to like OB-GYN, it falls before the onset of menstruation. And so when that falls, basically you don't have as much allopregnanolone, and so you don't have as much modulation of the GABA A receptors. Basically, it is related to the pathophysiology of PMDD. That's why girls can get mood disruptions right before the onset of their period, because those hormones are dipping off. And then also the failure of the GABA A receptors to adapt to the abrupt decreases in progesterone and allopregnanolone may contribute to postpartum depression. And so there's actually a drug that I learned about, brexanolone, which is a synthetic form of allopregnanolone, has been approved for the treatment of postpartum depression. So I thought this was really interesting just to kind of tie in a different theory for depression. So some more background, just integrating these two theories together. SSRIs are used to treat both PMDD and MDD, and subjects with MDD treated for 8 weeks with SSRIs had an increase in occipital cortical GABA levels and decrease in depressive symptoms. So that's kind of showing there's a connection between using an SSRI long term and it affecting the GABA system as well. And then use of SSRIs to treat disorders related to low progesterone, allopregnanolone, and GABA levels combined with a delay of clinical improvement for weeks is consistent with a theory that monoamine antidepressants eventually exert their effects by correcting deficits in the GABA system. So kind of what I said, eventually the serotonin reuptake inhibitors do affect that system, but it's not completely understood, but they do seem to be intertwined. So now some more background. Another theory, we all know the vagus nerve is a great relaxation nerve, and so the vagus nerve and GABA are also interconnected. So research has shown that increased vagal nerve stimulation can increase GABAergic activity. And just, briefly going over the vagus nerve, ways to activate it are exercise, deep and slow breathing, meditation, singing, laughing, yoga, and relaxing. So kind of all things we like to do, just kind of chill us out, make us feel good. And then here's just a little picture of remembering kind of how the vagus nerve affects the organ systems. Basically, it like slows everything down. And so now a background just tying together yoga and the GABA system. So like I had talked about before from my literature review, there was a lot of increasing evidence from randomized control trials that yoga interventions are associated with decreased depressive symptoms. But through this, it was just a lot of trials of, people practice yoga and over a course of time and their depression kind of improves. But the mechanism behind it was relatively unexplored. Just like, as I said, many studies were using subjective scales. And so also, but there have been a few studies prior to this publication that showed that yoga interventions have been associated with increased GABA levels in experienced practitioners after a 60-minute hatha yoga session, yoga-naive healthy controls after a 12-week Iyengar yoga intervention, and individuals with MDD after a 12-week Iyengar yoga intervention. So there was some basis prior to this study, kind of intertwining yoga with the GABA system. And so now just a quick little background slide on different types of yoga, just so that it doesn't seem like what I'm talking about is, I don't know, just so there's like a background. So Hatha in Sanskrit, it's just basically an umbrella term for all the physical postures of yoga. It means kind of grounded in physical practice. And here in the United States, Hatha yoga is generally like a good beginner physical practice or physical posture kind of class to take. Iyengar it focuses on alignment as well as like detailed and precise movements with breathing. So that's the kind of yoga they did for this trial. A few other kinds that are the main kinds practiced over here. Kundalini is definitely more spiritual and physical, and it's aimed at releasing the Kundalini energy in your body trapped or coiled in the lower spine. Ashtanga in Sanskrit, Ashtanga means 8-limb path. It's a very physically demanding kind of yoga class. It follows a specific sequence of sun salutations. So there's usually like 5 sun salutations A's and then 5 sun B's, and then it moves into a series of standing and floor postures. That class can be non-heated or heated. Vinyasa means like flow, so it's more flowy yoga. It's adopted from Ashtanga, and so basically, you're flowing and doing sun salutations and series of standing and floor postures, but it's not as strict, and so there's more room for creativity in those classes, and that can be heated as well. Bikram might be, in my opinion, like the most strict kind of yoga. It's in a very hot room that's 105 degrees and 40 degrees humidity, and it's a sequence of set postures. There's 26 basic postures performed twice, and then yin yoga is slow-paced, relaxation, like restorative, and that should say meditation, and the postures are held up to 2 minutes, and they're supported postures, so gravity does a lot of the work. And so my favorite kinds that I like to do are I like Kundalini for the spiritual, Vinyasa is my favorite kind of practice, and then Yin is the most restorative. So now we're finally to the article. So here's the article I chose. I already said it, but it's from the Journal of Alternative and Complementary medicine, and it's about thalamic GABA level changes in MDD after a 12-week Iyengar yoga and coherent breathing intervention. So the hypothesis was that the Iyengar yoga intervention, including coherent breathing at 5 breaths per minute, increases parasympathetic input into the brain, which is associated with increased GABA levels and decreased depressive symptoms. So before we start, I wanted to take this time to do a quick breathing exercise, probably just for like a minute. So if you're not into it, you can just scroll forward. But if you are, I invite you to just begin to ground yourself. Feel your feet on the floor. Take a deep breath in and then exhale. Allow your hands to rest gently on top of your thighs. Relax your shoulders, your neck. Release any tension in your jaw. And now gently just close your eyes. And we'll just do about a minute of coherent breathing exercises, which is just deep, elongated breathing to help activate your parasympathetic nervous system. So we'll begin. Inhale for 4, 3, 2, 1. And exhale for 4, 3, 2, 1. Inhale for 5, 4, 3, 2, 1. And exhale for 5, 4, 3, 2, 1. And go ahead and repeat this on your own for a set of 3 times. I'll give you about 30 seconds. On your next exhale, just keep your eyes closed, but begin to return to the natural cadence of your breathing. And now gently open your eyes. And just notice the difference, if you feel any difference right now. Such a little breathing exercise. So the methods for this article, the study design was a randomized trial. However, there was no control group, so the subjects were randomized into either a high dose group or a low dose group. The high dose group intervention were 3 90-minute yoga sessions and then 4 30-minute homework sessions each week. And then the low dose intervention was 2 90-minute yoga sessions and 3 30-minute homework sessions each week. Each 90-minute yoga session had 60 minutes of Iyengar yoga, 10 minutes of relaxation, and 20 minutes of coherent breathing exercises at 5 breaths per minute with equal inhalations and exhalations paced by an audio file. So similar to what we just did. And then the 30-minute homework sessions consisted of 15 minutes of postures. And like I'd spoken about, Iyengar is big on precise postures, so that's what they were focusing on. And then 15 minutes of the audio-paced coherent breathing. The subjects were randomized using a permuted block design. The subjects were not blinded, so they knew what group they were in. And then the Boston University Medical Center staff was also not blinded, so they were the ones helping with the yoga interventions. But the McLean Hospital staff, they were the ones who collected and analyzed the spectrum data for the GABA levels. They were blinded, so when they were analyzing the different data, they didn't know what group the subjects were from. And then the subjects completed their own Beck depression inventory to reduce risk of outcome assessor bias. Continuing with methods, the inclusion criteria was for age 18 to 65. a Beck Depression Inventory 2 score of greater than 14. Comorbid anxiety disorders were allowed if they didn't interfere with the ability to participate in the yoga interventions or be in an MRI scanner. Treatment with antidepressants were okay as long as they weren't changing antidepressants and they had been stable on that antidepressant for over 3 months. And then it was okay to have suicide ideation, but without intent, using the Columbia Suicide Severity Rating Scale. And these inclusion criteria changed a little bit just to be able to include people, but these were the final inclusion criteria. The exclusion criteria was treatment with benzos, mood stabilizers, or psychotherapy in the 3 months prior to screening, greater than 6 1 hour mind body practices in the last 6 months, just because, that's kind of what that would be the intervention already, or a current prayer practice of greater than 2 hours per week. Bipolar disorder, history of psychosis, suicide attempt, or SI with intent within the last year using the Columbia Suicide Severity Rating Scale criteria, or alcohol or substance abuse or dependence. And then, kind of going back to when I spoke about GABA relating to progesterone, so the females were required to have a serum progesterone level of less than 0.3, consistent with the follicular stage, to avoid changes in GABA levels during the menstrual cycle before scan 1. And then for scan 2 and scan 3, they wanted that same level, but if it was greater than that, they could have a negative pregnancy test and stay in that. So they just didn't want any of the hormones to be affecting the mood. And later in the presentation, I'll go over kind of what it means, like the different scans mean. So that'll be coming. Methods continued. So what I had said about the different yoga protocols and homework is outlined right there. I said that earlier. And then as far as the MRI and proton MRS scans, they scan the left thalamus was the region of interest because it is functionally connected to brain regions associated with mood regulation and provides high quality spectral data from deep gray nuclei with high concentrations of GABA. So here's the study design that I was speaking about. Basically, first you can see it kind of going across. The screening process happens, and then it's imaging session 1, basically like scan 1. And so they do a Beck Depression Inventory, and then they get their MRS scan 1 to just measure that baseline GABA level. After that is when the randomization occurs, so they go either into the high dose group or the low dose group. They do that 12-week yoga intervention depending on what group they're in, and then it's all imaging session 2. So basically, after that 12-week yoga intervention, they get MRS scan 2 to see what happens after that 12-week. Then all the participants do a yoga session. They complete, after that yoga session, right after it, they'll complete another Beck Depression Inventory and then get a third scan. And that third scan kind of shows the immediate effects of yoga. And that yoga session was a 90-minute yoga session. So here's some of the results. The first one is the recruitment to get subjects for the study. So the recruitment resulted in 265 volunteers being screened by telephone first. 179 were excluded, and you can kind of see above there the various reasons they were. And then 86 participated in an in-person screening visit and interview. And then from there, 54 were excluded. So they had 32 who kind of made it into the study. So they randomized those into the high dose group, into the low dose group. And then during the intervention, one from each group dropped out. And then you'll see on the next slide, only 13 remained in the high dose group that ended up getting scans 2 and scans 3. So ultimately, that's kind of how recruitment went. So this table just kind of shows the participant characteristics between the low dose group and the high dose group. And I just wanted to point out things that were statistically significant. So, basically age, education, and they're all, in their around in their 30s, like 20s to 40s, education around like high school level, and then most of them were female. But one thing that was different was in the low dose group, only 6.7% were menopausal, and in the high dose group, 38.3% were menopausal. So this will come into play later, but that has to do with the hormone changes that we talked about. And women who are postmenopausal, they don't have baseline as much estrogen, as much progesterone, so that can affect GABA levels. Kind of keeping going down this chart, the majority of them were Caucasian. The BMI was statistically significant, but just looking at the numbers, I mean, both groups are right around that, overweight category that most Americans fall in. And then I just wanted to point out that in one group, there was somebody on antidepressant medication. So in the low dose group, one person was on venlafaxine, they were stable on it. And then in the high dose group, one person was on bupropion. And then this table shows the results of the GABA levels during the study. And so it has the different GABA levels for the different scans, and then the whole cohort put together, and then separated out the low dose group and the high dose group. So when you kind of just briefly look at the chart at first, you can see overall the whole group from the scans, the GABA levels do increase. And then when you look at the low dose group, they increase the most, kind of going down. And the high dose group actually is not what we expected. So that one shows basically the same thing between scan 1 and scan 2 as far as GABA levels, and then for scan 3 it's actually a drop. So overall, the t-test revealed no statistically significant differences between the low dose group and the high dose group for GABA concentrations for any of the 3 scans, although there was a trend at scan 3 for a higher GABA concentration in the low dose group. So now we'll go to the next slide to look at the percentage changes in the GABA levels between the different scans. So from this chart, I just want to point out the statistically significant findings. So for the GABA level for the total group between scan 3 and scan 1, or from scan 1 to scan 3, the t-test comparing the relative percentage changes in GABA levels between those scans showed a statistically significant trend for increased thalamic GABA levels at scan 3. And then from there, as you kind of keep going down, when separated between the low dose group and the high dose group, that same comparison between scan 1 and scan 3 showed a statistically significant increase in the GABA level for the low dose group, but not for the high dose group. So you can see the total highlighted in the low dose group between scan 3 and scan 1 are showing a statistically significant increase in GABA levels. So from the beginning of the study to scan 3, which was after the 12-week intervention and after that final yoga class. And so now moving one column over, comparing scan 3 to scan 2, and kind of doing the same thing. So comparing the total cohort, it showed a trend for increased GABA concentrations at scan 3 that was statistically significant. So from scan 2 to scan 3 was that right after doing that one-time yoga class. And then it also, again, just breaking it down again between the low dose group and the high dose group, the same comparison showed a statistically significant increase in GABA for the low dose group, but not for the high dose group. And then comparing scan 2 to scan 1, there were no statistically significant findings in GABA concentrations between those scans. And since there were no statistically significant findings from those scans, and that was kind of unexpected because between scan 1 and scan 2 was that whole 12-week intervention. The researchers wanted to look more at potential factors affecting the GABA levels between those scans. So, Table 4 shows different participant characteristics and then an increase in GABA levels between scans 1 and scans 2. And basically, of the 28 participants who completed scan 2, 14 of them had an increase in thalamic GABA levels from scan 1 to scan 2, 7 from the high dose group and 7 from the low dose group. And then 14 had a decrease in thalamic GABA levels from scan 1 to scan 2, and it was 6 from the high dose group and 8 from the low dose group. So it's kind of 50-50 split between who would have an increase in GABA levels and who would have a decrease in GABA levels. And so since this was pretty unexpected, a logistic regression was performed to determine whether there were participant characteristics that predicted whether an individual was a GABA responder, and that if there's something that predicted whether their GABA level would increase over the course of a study. And so one kind of important thing that they found was that the number of days between the last yoga intervention and scan 2 was significantly associated with increase in GABA levels from scan 1 to scan 2. So basically they found that GABA levels were higher at scan 2 when participants had been in a yoga class within kind of the last 4 plus or minus 3 days. And they found that the GABA levels were lower in participants, and they did not increase in participants who had been their last yoga intervention before scan 2 was, around 8 days before that. And so basically it was like the difference in days before they got their scan that they found that was statistically significant. So that's what that first part, the last scan, means. And then there was also a trend in participants with a higher baseline Beck Depression Inventory score were more likely to have increased GABA levels at scan 2. So people who were more severely depressed did seem to respond more. So now the results of the Beck Depression Inventory scores are in Table 5. And basically this whole table is statistically significant. And so you can look at the whole group, and basically between everything their scores went down. So what's interesting from this though is that when you're just doing a subjective scale, the high dose group actually had a bigger response. Like their, Beck Depression Inventory score went down a lot more than the low dose groups did when you just look at those numbers. But overall, their subjective depression symptoms did improve all the participants. And then this is just another way to kind of view the results of the Beck Depression Inventory and versus like cumulative yoga, and this is showing the low dose subjects. So you can see kind of around maybe like week 8 or week 9 is where that cross point happens as far as like their Beck Depression Inventory dropping and their cumulative yoga total going up. And what's interesting is when you compare it to the high dose group, that cross point kind of happens earlier. So it seems that their depression subjectively decreases more quickly in the high dose group, and they're doing more yoga, the intervention's a little bit more intense. So that's kind of just that result. And then these are the results comparing the Beck Depression Inventory in relationship with the GABA levels. So kind of integrating everything together that I've gone through. So a Pearson correlation analysis was used to evaluate the relationship between the Beck Depression Inventory scales and GABA levels at scan 1 and scan 3 and percentage change between scan 1 and scan 3. And so at scan 1 and scan 3 time points, there were no statistically significant relationships between Beck depression inventory scores and GABA levels for the total group, the high dose group, or the low dose group. But when comparing changes in Beck depression inventory at scan 1 and scan 3 with GABA levels between the two scans, results also show no significant relationships for the total group or the low dose group. But there was, however, a statistically significant inverse relationship between changes in the Beck depression inventory scores and GABA levels for the high dose group. So that kind of supported showing that as GABA levels increased, depressive symptoms decreased. So in summary, the low dose group exhibited a significant increase in GABA levels from scan 1 to scan 3 and from scan 2 to scan 3, but not from scan 1 to scan 2. The trends for the total cohort were to have an increase in GABA levels from scan 1 to scan 3 and from scan 2 to scan 3. So, just GABA levels were trending up the whole study. Potential factors that were affecting the GABA levels. So it's kind of what I spoke about before, time since the last yoga class. So when they were looking at the differences between scan 1 and scan 2, basically GABA responders were people who had taken a yoga class within the last 4 days. If they had taken it outside of like an 8-day interval, then they weren't GABA responders, which just kind of shows more of like a time dependence response to yoga. And then also another potential factor affecting GABA level was the baseline Beck depression inventory score. So they found that people that had a higher baseline responded more to the yoga therapy. So it could be that, their depression's more severe, it's just ready to respond to stuff. And then some more summary points. Participants with a shorter time interval between the last yoga class and scan 2 were statistically more likely to show an increase in GABA levels at scan 2, with the number of subjects evenly distributed between both groups. So kind of what I was talking about, it's that time dependence thing after class. And then there was a significant association between changes in Beck depression inventory scores and changes in the GABA system in the high dose group, consistent with the GABA deficit hypothesis of depression. So, it's that inverse relationship of depressive symptoms will increase if you've got low GABA, but if you've got high GABA, depressive symptoms will get better. So, kind of some overall discussion from this. It basically suggests that the time from the last yoga class to scanning may have a greater association with increased GABA level than the assignment to the group. And it's kind of that point I've talked about a few times, but there were 7 people from the high dose group, 7 people from the low dose group who were GABA responders, but they had just taken yoga classes sooner before getting scan 2. And then this is also consistent with the observed increase in GABA from scan 2 to scan 3. So in that whole cohort, the GABA levels increased between scan 1 to scan 2 and then scan 2 to scan 3. And between scan 2 to scan 3 was just that one yoga class. So that's consistent. There's a time dependence increase in GABA after taking a yoga class. So it's probable that the effects of yoga sessions, like pharmacologic treatments, are time limited. And this kind of goes with the yoga tradition that advocates for a daily practice. And the increase in GABA levels after yoga was observed for an average of 4 days, but no longer observed after an average of 8 days. So it suggests that, at least one yoga session a week may be necessary to maintain those elevated GABA levels that you achieve from doing something like yoga. The strengths of this study were that it was a randomized control trial. There were blinded staff for the GABA level analysis, and then all females except one were scanned in the follicular stage. The limitations were that there was a lack of an active non-yoga control group. It was definitely a small sample size. Interactions with a supportive group and interactions with research staff may have impacted outcomes. It lacked a clinician administered depression scale with blinded rater. And then the MRS was limited by only measuring the presence of GABA, not cellular location or receptor activity. the lack of the bilateral thalamic data prevented the examination of lateralized changes. So they only looked at the left side. And then another limitation is it's kind of difficult to apply to, you know, the patients we see in Harding in clinical practice, as the study population was pretty treatment naive with all of the exclusions. So the future direction of this would be to include a control group, have a larger sample size, administer a clinician administered depression scale by a blinded rater, and then look at the bilateral thalamic data. And kind of the main conclusion from this, so there was like a lot of data that I talked about, but the main thing and the main conclusion that came from the study was yoga interventions like pharmaceuticals are time limited. So every day if you take an SSRI, that's something you do every day to help maintain a level. Yoga's no different. So they found that there's a time dependence dose response in GABA between these groups, and that has to do with practicing yoga. So basically, yoga practice of at least once a week is needed to sustain elevated GABA levels. Also, just another, conclusion is in that high dose group, there seemed to be not as much of a response. But when looking at the Beck Depression Inventory Scale, the high dose group responded really well. So subjectively, the cohort did great in this study. And one more thing about the high dose group, if you remember me highlighting in the beginning, one main difference between the high dose group and the low dose group was the high dose group had statistically significantly more postmenopausal women. So that kind of ties in with the GABA deficit hypothesis that the high dose group might not be as much of a GABA responder because baseline, the high dose group didn't have participants with as much baseline progesterone. But ultimately, like I said earlier, the big conclusion from this is yoga interventions are time limited, but can help with not only major depressive disorder, but can also help elevate GABA levels, which is something novel and new that really hasn't been studied much until this. So these are my references. And then I just wanted to say thank you. So a special thanks to Dr. Jessica Lammers. She served as my mentor for this journal club. And then thanks for taking the time out of your day to listen to this and learn more about yoga and GABA levels and the GABA deficit hypothesis. If you have any questions or comments about this, feel free to email me. My email is right there on the slide. And I hope you have a great rest of your day, and namaste.